So thank you for joining us for this ASME Bite-Size. We'll be looking, during this presentation, at clinical reasoning. We'll be looking at the what, the how, and the scholarship. Before we go into the presentation, what I'd like to do is we're going to introduce who we are and what we'll be talking a little bit about during this presentation. This particular bite size links in with a live Q&A interactive session. So we hope that what we discuss in this presentation will trigger some interesting questions that we can pick up in the discussions on the 4th of November. Who are we? I'm Mark Lillicrap. I'm a rheumatology consultant based partly in Cambridge, partly in Huntingdon, and I'm involved with teaching clinical reasoning to both medical students and to postgraduate trainees. I'm involved in both clinical teaching and in small and large group teaching. And I'm also on the board of ASME, and I'm on the organising committee of a group called the UK Clinical Reasoning in Medical Education Group, also called CREAM. I'll hand over to Nicola so she can tell you a bit about who she is.
Hi, my name's Nicola Cooper. I'm a consultant physician and also clinical associate professor in medical education. I teach on the Masters in MedEd at Nottingham. I work mainly in the specialty of acute medicine and have an interest in how we teach clinical reasoning and how clinical reasoning ability develops, and I'm chair of CREAM.
Simon.
Hello, my name is Simon Gay. I'm a GP. I'm Professor of Medical Education Primary Care at the University of Leicester School of Medicine. I'm involved in teaching clinical reasoning to undergraduates and postgraduates, and I am currently Treasurer of CREAM and Deputy Chair of ASME's Educated Development Committee.
Thank you. So that's who we are. We're going to talk a little bit about clinical reasoning. The way this evening's going to be structured is we're going to introduce a little bit about what we mean by clinical reasoning, and then Nicola has prepared a short video introducing a bit about the what of clinical reasoning. We'll then discuss a little bit more about the what and what that means in teaching practice, and then we're going to come on to the how. And as we go through that, we'll be linking that a little bit with some of the scholarship of medical education based on some of the work that CREAM's been doing, based on some of the common educational models that many of you will be familiar with. What do we mean by clinical reasoning? So this is a definition from Michelle Daniel, published in Academic Medicine last year. Clinical reasoning is a skill, process, or outcome wherein clinicians observe, collect, and interpret data to diagnose and treat patients. It entails both conscious and unconscious cognitive operations, interacting with contextual factors such as the patient's unique circumstances and preferences and the characteristics of the practice environment. Quite a nice summary definition of what we mean by clinical reasoning. Things to pick up: it's not just about diagnostic reasoning. It's got elements around the patient, it's got elements around the thinking process, it's got elements around data and how we utilize data. And we're going to pick up all of those elements as we go through the presentation. So without further ado, I'm going to launch into the video, and the video looks a little bit in detail at the what of clinical reasoning. As CREAM, we've been doing some work looking at what is the scholarship around clinical reasoning, what should we be teaching, how should we be teaching it, where should we be delivering that teaching, and so we're going to pick up on all of those elements as we go through. First of all, the video.
Hello, my name's Nicola Cooper and I'm a consultant physician and also a clinical associate professor of medical education, and I'm chair of the Clinical Reasoning in Medical Education Group. Clinical reasoning can be defined as a process, an outcome or a skill whereby clinicians gather, interpret and data in order to make a diagnosis and treat patients. It involves cognitive and non-cognitive operations and is also influenced by contextual factors such as patient factors, the local healthcare setting, and so on. Clinical reasoning is vital for patient safety because we know that clinical reasoning, the thinking and decision-making processes associated with medical practice, is fundamental to diagnosis and then management. But we know that diagnostic error occurs in 10 to 15% of cases, particularly in the undifferentiated specialties such as general practice, emergency medicine and internal medicine. It's estimated that each of us will experience a diagnostic error in our lifetime, and diagnostic error is the most common, the most costly, but also the most dangerous of medical mistakes, and is the leading cause of negligence claims in the UK and the US, for example. So diagnostic error is important and a leading cause of harm. And it's of interest to educators because if we can teach the clinical reasoning process better, we may be able to improve outcomes for patients. And that ultimately is the goal of medical education. Now, educators have been interested in clinical reasoning for many years now, but a seminal report from the US Academy of Sciences in 2016, Improving Diagnosis in Healthcare, pointed out that while system factors, things like human factors, have been a real focus of patient safety efforts in the recent decade, we've neglected the diagnostic process. And this report really emphasises that educators should explicitly address the diagnostic process in the healthcare profession's curricula, using evidence that's aligned from the learning sciences. So for this first introductory video, I'm going to tell you a little bit about the consensus statement on the content of clinical reasoning curricula for undergraduate medical education that me and my colleagues in CREAM have developed. And I'm going to start with talking about the what of clinical reasoning education. And in the webinar that follows, we're going to talk about the how, because there's actually really good evidence for how we can teach in a way that's most effective in improving diagnostic performance among medical students. But first, let's talk about the what. Well, myself and colleagues representing 12 medical schools across the UK got together for a day to discuss the what of clinical reasoning education at medical school. And through a process of discussion, we identified 5 domains of clinical reasoning education. The first is clinical reasoning concepts, because in order to talk about clinical reasoning, it's important that both teachers and learners have a shared understanding and a shared vocabulary in order for learning to be meaningful. The second domain for clinical reasoning education that we identified is history and physical examination. The third was choosing and interpreting test results. The fourth was problem identification and management. And the fifth was shared decision making. And I'll explain a bit more what we mean by those terms next. Teaching clinical reasoning concepts alone does not improve performance. Knowledge, formal and experiential, is fundamental to diagnostic accuracy. So in addition, the second domain of clinical reasoning education was history and physical examination. Obviously communication skills are important, but learners should appreciate that the patient's history can also come from other sources, not only the patient. And they should be able to explore symptoms through hypothesis-driven inquiry, and this should extend to the physical examination. Learners should be able to synthesize data from the history and exam to be able to judge the clinical probability of disease using their knowledge of epidemiology, the probability of the presence of particular symptoms and signs, and likelihood ratios, in other words, how good those signs are where relevant. While we might teach typical presentations of diseases and simple lists of features in early years, by graduation learners need to have a clear understanding that many patients do not present with the classical features of diseases as described in textbooks.
So you think I have to see neck stiffness, I have to see a very high temperature, I've got to see a rash and think of meningitis. I've never actually seen meningitic rash, and but a lot of patients do come in early. So unfortunately, if you're waiting for a rash, if you're waiting for neck stiffness, if you're waiting to get a Koenig sign or a Brzezinski sign, you'd never actually treat meningitis. So it boils down to actually understanding that things don't come in textbook.
This evidence-based approach to history and physical examination is absolutely vital because diagnostic test results need to be chosen appropriately and they need to be interpreted in the light of the clinical probability. Having gathered sometimes a vast amount of data from history, physical exam, and sometimes initial test results, learners need to be able to encapsulate, to synthesize, and decide what the problem is. In medicine, this is called the problem representation, and that's an absolutely fundamental skill. The ability to encapsulate a problem clearly using semantic qualifiers and precise medical terms before thinking through potential diagnoses is an important skill that helps to organise and retrieve knowledge from long-term memory relevant to the case and is associated with higher diagnostic accuracy, particularly in complex cases. Finally, by graduation, learners need to develop the skills of shared decision making, and that's not only with patients and carers, but it's within teams, using evidence-based guidelines, technology, scores and decision aids. In the real world, knowledge is not something that's all in your head. It's distributed throughout the environment in people, computers, books and other tools and instruments. Well, that was a very brief introduction to the 5 domains of clinical reasoning education, or the what. We'll discuss your questions and more about how to teach in the webinar.
So during the video, we picked up these 5 key domains. So we had clinical reasoning concepts, history and physical examination, choosing and interpreting diagnostic tests, problem identification and management, and shared decision making. So they're the key whats around clinical reasoning. And to start with, we're just going to unpick that. And I'd just like to hand back to Nicola a moment. So you mentioned during the video, history and physical examination, choosing and interpreting diagnostic tests. Playing devil's advocate, isn't that what we all teach anyway? How does that link in with clinical reasoning, Nicola?
Thanks, that's a really good question. So yes, in one sense, the basics of the diagnostic process are taught at medical school, and medical schools differ from one another as well. But what we see when people approach graduation and also after graduation is that some of those skills needed to make decisions, the knowledge and skills, haven't quite been emphasised during their training. Tenny, who was our junior clinical fellow in that clip, put it wonderfully. She said, I was taught that meningitis was headache, fever, and neck stiffness and rash. And then she said, but patients don't always have neck stiffness, and I've never seen a rash. And if you're looking for a rash and Koenig sign and Brzezinski sign, which, by the way, happen in less than 5% of patients with meningitis, you'll never diagnose a case of meningitis. And so I see even senior trainees in my hospital practice who don't know basic concepts like likelihood ratios. The fact that in UK practice, less than half of patients with meningitis, including bacterial, will not have neck stiffness on physical examination. And so this is this idea of evidence-based history and exam, that you use your knowledge, not just of epidemiology, to think about the group to which the patient belongs, but also an understanding of the probability of finding those signs in patients with diseases, and then the weight how good those signs are, or likelihood ratios. And all of that is synthesized into the clinical probability, the pre-test probability, because that clinical probability is absolutely key in deciding whether to do a test and also interpreting the test. Now, this, of course, is a challenge for teachers everywhere, because the Sutton report published something called What Makes Great Teaching. You can find that online. And the two top things with a high amount of evidence were, number one, the teacher had a strong knowledge of the content to be taught. But number two, a good knowledge of how to instruct, how to teach as well. And so that is a challenge, I think, for medical schools and postgraduate training programs and all of us.
Excellent, thank you. So you've segued very nicely into the next challenge, which is, so there's the what we incorporate into clinical reasoning teaching, and then there's the how. And in the consensus statement that Cream put together based on the review of the scholarship, there were 6 key areas that were highlighted in the scholarship in terms of how we operationalize this. How do we actually deliver the teaching? Nicola, did you want to give us a little bit of an intro to these 6 key hows, and then we can unpick a little bit about what that looks like in practice?
Sure. So there's been lots of studies in the literature, but the clinical reasoning literature has been described in the literature as fragmented. In other words, it's in cognitive psychology, it's in education, it's in the patient safety literature, and it can be very difficult for clinical teachers to access in a way that's just easy to reference and incorporate scholarship into your own everyday teaching practice. But this is what we found when we reviewed the literature, and also this has very practical application for teachers as well. So in point 1, what we mean by strategies that build understanding is simple things like experiments have shown when students understand the basic science mechanisms behind symptoms and signs, they're more likely to remember them. For example, if we go back to our meningitis example, only people with severe meningeal inflammation have bedside signs of meningism. That's just one example. There's a lot of research on reflection. There's a meta-analysis on reflective strategies in diagnostic decision making. I think that's by Prakash et al. Quite recently. And that can be as simple as asking students, what's the evidence for this? What else could it be? But there are other things you can do as well, including things like self-explanation, which we might talk about in a bit. Practice cases with feedback, that's just part of deliberate practice theory, which you may have heard of from Erickson. But that coaching and feedback is absolutely key. Structuring knowledge is key as well, and we need to think about how we teach, because we often teach in a way that is giving knowledge, but not necessarily in a way that's helping learners structure their knowledge around how to tackle a problem. And I'll just give you one really nice example of a study by Coder et al., where they had final year students of the same knowledge levels, which they tested them on beforehand, and then they asked them to solve some common clinical problems. One example was anemia. And what they found was that the high performing students had a structure of how to approach the problem. They structured their knowledge around the problem in the same way that experts do. The low performing students just spoke about anemia. The high performers said, what's the MCV? If it's low, I'll do this. If it's normal, I'll do this. If it's high, I'll do this. So there's something about, and we know from the literature in clinical reasoning that experts structure their knowledge differently, and that's why they're more effective. Retrieval practice is a well-known learning strategy to get knowledge into long-term memory, and we know that knowledge is absolutely key to diagnostic performance in studies. And then finally, you can't teach a first-year clinical student in the same way as a final year, and that's to do with cognitive load. So at the beginning, we're very scaffolding, high instructional support, low fidelity tasks, moving through to, by the time of graduation, low instructional support, high fidelity tasks. You have to have that progression through medical school and postgraduate training so that people can practice and learn in a really authentic way.
And I guess it's reassuring that although, as you say, the reasoning literature has been described as fragmented, the evidence-based approaches that we can take actually link in with models that all of us are actually quite familiar with. You know, you've got cognitive apprenticeship in those stages of learning. We've got constructivism and experiential learning cycles around the way that we build our understanding. Sean's work on reflection in action and the importance of structured reflection. So it all links together, and it's reassuring that the good evidence that's out there actually picks up other evidence-based, other models and frameworks that we use in our teaching. There were one or two things that before we stop the slide share, it might be worth noting weren't shown to be helpful in teaching clinical reasoning. Did you want to say anything about that?
Yes. So what's really interesting is especially in the last decade or so, many teachers, many educators have become interested in clinical reasoning, and we've been teaching people the principles of clinical decision making in the form often of short courses. And that's great for introducing the concepts of clinical reasoning so that we can then have a shared vocabulary. But we know quite clearly from the research that just teaching the principles of how we think, teaching about cognitive biases, for example, there's no good evidence that alone makes any difference at all. It's about mainly building understanding, but also some of those strategies around reflection as well at the moment.
Excellent, thank you. I'm going to stop sharing the screen so we can have a little bit of a discussion. I'm going to hand over to Simon. Simon, obviously you do a lot of teaching, both in terms of formal teaching and in the primary care setting. So how do we do this? How can we take this scholarship and apply it in our teaching practice?
Thank you, Mark. I think that's a really pertinent point that you're guiding me towards there, because with all this theory, and it is reassuring that all these fragmented elements do actually connect reasonably well when you take the time to consider the challenge. But we still have to translate it into ways in which everyday education can meaningfully employ them. And knowing the theories and knowing the underpinning doesn't necessarily translate immediately at first glance into strategies that we can use in a busy clinical setting. So the sorts of things that I think of in those sorts of terms are things like making sure that we inculcate vocabulary into learners so that they can meaningfully explain their thinking and share their thinking with the tutors. And of course, for many tutors, there's also a self-development element there, where many of those will have come through their own clinical education before clinical reasoning was really at the forefront of people's discussions. So they may too need to familiarize themselves with the relevant vocabulary. I think taking that one step further, it's very useful if where informal language comes up, we actually challenge that. So for example, we know that learners have a higher diagnostic success rate if they use semantic qualifiers. So we can encourage that sort of use of language.
Yeah.
I think we can also think constructively. When I'm talking about constructivism here, I'm thinking about creating situations that, in order to escape from the situations, if I can use that term, the learner has to engage in clinical reasoning. And they might do that without even necessarily being conscious that that's what they're doing. So even simple things like promoting presentation skills, but adding in the requirement for them to summarize the consequences of their presentation rather than just deliver their findings. Also challenging thinking when those presentations are given, if thinking is evidently incorrect, and even challenging it where it is correct, just to make sure that they've got to the right endpoint for what are actually the right reasons in that specific context. We already mentioned deliberate practice. I think also it's worth mentioning here, you can actually create comparative learning. So you can let a learner interact with you about a particular clinical case. But then when they've done that, you can say, if I change this, or the presentation was slightly different, what would that change about the whole scenario? And that comparison can sometimes open mental doors that don't open if you simply describe one aspect of the case.
Yeah.
And probably the last thing to say, which is particularly pertinent for me as a primary care clinician, where there are lots and lots of patients going through every day, either virtually as currently or more normally in physical presence, is to encourage the learners to anchor their interaction with you specifically to the patient they've seen. Because we all often, when we ask learners a question, will get a regurgitation of their book learning, which is relevant to the scenario, but perhaps isn't relevant to the specific patient. And I think that comes back to Nicola's comments about odds ratios and probabilities, and actually taking all of the information available to you into account.
And it's interesting listening to you talking there, because again, it maps into those, how do we do teaching, things like the 1 minute teacher. The 1 minute teacher picks up many of those kind of points. He's starting with that open-ended question, what do you think's going on here? And then you need to stretch the learner's thinking with, well, what would be different if, and why did you not think about this? And then we pick up the things that they've done well, some generalizable points, things that they could do differently another time. And so I think, again, it's a case of a lot of the frameworks that we discuss are actually very applicable to the reasoning teaching on the ground. Nicola, you're more on the secondary care side. How do you apply these principles in more of the secondary care context?
Well, would it be okay, Mark, if you showed the what slide again?
Absolutely.
If we share that, because just to remind everyone, members of CREAM got together with representatives from lots of different medical schools, and we spent the day talking about, what of clinical reasoning, and what is it we should be teaching at medical school or through a clinical reasoning lens. And this is how we ended up with these 5 domains. But what I find really useful as a teacher is that this helps me diagnose the problem. So, for example, when whether it's a medical student or an F1 doctor or a medical registrar, when they are coming to ask advice or presenting a case, or we're reviewing a patient together, as an educator, I can pinpoint where their problem may be, where a knowledge gap may be, or a misunderstanding might be, or whatever. So, for example, it may be a really common example is, if I might say, could it be a pulmonary embolism? And they'll often say things like, well, the patient's oxygen saturations are normal and they didn't have any chest pain. That's a lovely example, because that's a common misunderstanding about how PE presents. And going back to the reflection thing, instead of telling the answer, you can say, well, let's just think about what you've just said. What's the most, how does PE present? The other thing is, sometimes there may be a misunderstanding about interpreting tests. So a common example is, the troponin that is often mildly elevated in 50% of people over the age of 75. So an elderly woman had fallen, no chest pain, normal ECG, troponin mildly elevated, and the F1 doctor said, shall I put this patient on treatment for an acute coronary syndrome? And I said, well, let's just think about what you've just said. What's the clinical probability of an ACS in this patient? And he said, well, no chest pain, normal ECG, she had a fall, I think it's very low. I said, great. Did you know that 50% of over 75s have a mildly elevated troponin? He said, no, I didn't know that. I said, well, that's why it's called highly sensitive. You can have those tiny conversations through the course of a day. But if you add up all those tiny conversations, that's a lot of learning in a shift. And I just want to mention something about problem identification, and hopefully Simon will add to this as well. This is so neglected, I think, by teachers in medical training. There's lots of research on problem solving. There's a whole branch of psychology, I think, on problem solving. There's a Cambridge handbook of problem solving. But one of the key things is that you have to recognize there's a problem in the first place, but then you have to do something called problem representation. That's a mental model of the problem in your head before you can then go on to attempt to solve it. And the research shows that experts spend quite a long time doing this before they move on, but novices don't, and therefore they often solve the wrong problem or make mistakes and have to go back again. In medicine and in clinical reasoning, the problem representation is that synthesis, that one line, that summary of not the presenting complaint and not your diagnosis, but it's what's going on here. So you're a rheumatologist, so a wonderful example, I'm just going to think of one, might be, 2-week history of migrating polyarthropathy and fever. Did I do okay?
You did very well. Absolutely. Yes. So I might ask you, so picking up on what Simon said, so what do you think might be going on?
So the act of doing that very precise problem representation, and as Simon said, using semantic qualifiers, so they're these abstract, acute, chronic, poly, mono, that kind of thing, and precise medical language helps you to retrieve knowledge from long-term memory and has been shown to be associated with higher diagnostic accuracy, especially when it's more complex relative to the learner. And a lot of medical students don't do that because they haven't been taught and they haven't been able to practice. And so they will say, swollen joints, and then they'll come up with fairly random things that aren't relevant to that case, if that makes sense.
And I'm guessing, just listening to that scenario, a nice follow-on question might be, so how would your thinking be different if they didn't have a fever? And get them to explore a little bit about how that's influencing their thinking. So yes, they're very helpful in terms of moving from the what, as you say. The what is about, in some ways, in that sort of clinical teaching moment, it's about how you diagnose what the problem is, and then the how is about, well, how can we move this forward? How can we improve your learning in this situation?
And the how is very good for classrooms as well. Very good for classrooms, not just but I find the what particularly helpful in the clinical setting.
Can I just offer
Simon?
Just offer a parallel here, and I'll also briefly comment on the question that Nicola posed about problem identification. But before I go there, the cream 5 key domains there of the what fit very beautifully for 4 of them with a model that I've been using for many years in practical teaching, particularly with undergraduates. And one of the challenges with undergraduates for so many tutors, especially if they're teaching undergraduates from various different years and possibly from various different medical schools also, is to determine very quickly roughly where a student is up to in their personal development of clinical reasoning. And one of the models I've used to help me with that is a model that was developed by Lou Pangaro in the US called RIME, R-I-M-E.
Yes,
for reporter, which I would equate to our number 2 there. History and physical examination. If the student can perform a competent history taking and a competent physical examination and tell someone else what they found, then they're reasonably good at the R part of RIME. And then if they are, they're ready to move on to the I part, which is interpreting, which fits very neatly with the 3. The M is management, which fits very well with 4. And then if they can do all of those things, gather information well, report it to someone else, interpret it themselves, and then manage a situation as a consequence of that, then they are ready to move on to the E, which is the educator part. And that can be educated themselves or a colleague or actually the patient, which I would say fits fairly well with the shared decision.
And it also fits very nicely with moving up Bloom's taxonomy of learning.
It does.
Moving
it does.
Up the different domains. Yes.
So that's a very easy way to remember the domains there, I think. That's already been put into practice. And to come back to Nicola's point about problem identification and management, I think that's so important, the problem identification. And I would say from the literature, we're all slightly guilty perhaps of focusing too much or often only on the diagnostic reasoning. And then when you start to move to problem identification, which I think is much broader, we're moving away from the linearity of diagnostic reasoning and the complexity of reasoning in other aspects of patient care is anything but linear. There are so many multiple processes going on. I think they're all important, but I think it's important also to acknowledge that the wider reasoning is not as linear as the diagnostic reasoning is.
And it picks up a little bit more about the whole risk management and dealing with uncertainty in a way that perhaps the diagnostic reasoning framework doesn't acknowledge how you manage that uncertainty. And it anticipates that you will always have a diagnosis to work with, whereas I think the problem identification and management provides a much more open area in which to explore your reasoning strategies. Nicola, did you want to add anything else at this point?
Well, I mean, I trained in geriatric medicine as well as general internal medicine. And of course, in geriatric medicine in hospital, we often have a problem list, which we teach. And also, you know, you may have identified a whole bunch of problems, but you still not have a diagnosis because that's still a work in progress, and still not really know what's going on and be uncertain. But at least if there's, rather than focusing on what you don't know, if you focus on what you do know and the problems that you have identified, you've got a way forward then in sensibly and logically doing the next steps, which will hopefully eventually get you to the diagnosis, and you know, you can start a reasonable treatment plan and so on.
And I think that has very strong parallels with primary care clinical practice as a generalization.
And we've discussed quite a bit about the what. We've mentioned a little bit about the how. Nicola or Simon, did you have anything else you wanted to add in terms of how we can utilize some of these strategies in the how in perhaps on more of our teaching approaches? Nicola, do you want to go first?
Well, there's a nice little book called Small Teaching, which is to do with that you can just make very small changes in your teaching practice, which can have big benefits. And there's one book that I think all teachers should read, and it's called Understanding How We Learn, a visual guide, and it's by two learning scientists. And just let's take the example of retrieval practice. So in one nice study of teaching anatomy of esophageal echo in an intensive care unit or something, just the act of asking the trainees to name the structures before revealing what they were actually made them remember it much better than another group where they just went through the anatomy. And so just the low stakes quizzing and getting people to go into their long-term memory and retrieve as part of your teaching can make a difference to what we call making learning stick. So there's lots of small things that we can learn as teachers. We need to step back from explaining stuff, and we need to utilize the science of learning in terms of retrieval practice, self-explanation, structured reflection, and all those kind of things.
Simon, did you want to add anything there?
Yeah, I would firstly, I'd echo everything again Nicola's said, and I'd come back to something she said earlier on as well about the importance of cognitive load theory. I think we have to remember that many times when we're teaching learners, they are in a different place to us on their continuum, and we have to make sure that we aren't giving them so many aspects of the clinical reasoning scenario to deal with that they can't actually deal with any of them. And using small amounts of teaching frequently, I'm sure, is a more effective way forwards than spending less often with them and thoroughly overloading them. The other thing I'd play into that, it's a slight lateralization, but I don't think it's unreasonable, is to make students aware that when they have difficult patient behaviors participating in the clinical scenario, that can inevitably adversely affect clinical judgment for all of us. And that again is a form of pressure on their cognitive function. So firstly, empowering learners to realize that happens, just to increase their situational awareness. And secondly, to try and minimize other distractions that are within their control so that they have more bandwidth to deal with the cognitive load. And these are all things we learn over time, and we learn with experience, and you can't put an old head on young shoulders, but you can at least point them in the right direction so that when they are ready, they can make use of that information, perhaps when we're not around.
Yes.
We didn't really cover that, but picking up from that, clinical reasoning concepts includes things like understanding the kind of things that will impact on your ability to make good decisions and things you might do to mitigate those, as you know, understanding where your cognition can go wrong is something that helps the conversation and helps the teacher and the learner talk about these things, having that shared understanding.
Yeah.
And I would again echo the point you made previously that learning about things like biases does not change your ability to necessarily greatly improve your diagnostic thinking, but it does keep us all humble.
Yes.
And I'll just pick up from that, because it's interesting when we talk about the evidence, it's not quite the same as saying it's not the case, if that makes sense, because the evidence doesn't exist yet. I think what the evidence is that just doing a short course explaining about biases and so on doesn't work. And there's a bit of a debate at the moment about why reflection seems to work, and whether that's well, that's a whole long story, but we know that there's a whole science of the limitation of human performance called human factors, which all junior doctors now and medical students are being taught. And that is about understanding when your decision making might not be so good and what you can do about it, especially with things like night work and fatigue and interruptions and cognitive overload and so on. Yeah.
Excellent. Well, thank you to Nicola and Simon. This is to start a conversation. So we hope that some of the things we've discussed around the 5 domains of the what of clinical reasoning, the 6 sort of key strategies of the how, and a brief review that we've given of the scholarship has triggered you to think a little bit about clinical reasoning teaching, hopefully triggered some questions. We want to pick that up in the interactive Q&A session that's going to take place on Wednesday, the 4th of November. The ASME office are going to be in contact. It'd be great to get some questions in advance if there are things that you want us to specifically address. Alternatively, just bring along some questions that evening. We'll have an interactive chat so that you can contribute on the evening. So we've introduced a little bit about clinical reasoning. We've introduced a little bit about the what, a little bit about the how, and a little bit about the scholarship. Thank you for listening. We hope to see many of you in the interactive Q&A, and we'll pick up the conversation at that point. Thank you.